recorded just in case people know.
Oh, yes.
Yeah.
Got it. Everybody has to click. Okay, team, whenever you're ready, let's go.
In September 2022, the Translational Research Program welcomed its newest cohort of master's students. On this day, I met Mojan. We talked about our hobbies and our passions, how nervous we were to start this new chapter of our lives, but we also talked about our interest in mental health research. For me, that stemmed from my own lived experiences with the mental health system and my time working as a mood disorder research assistant. For Mojan, it was lived experiences, but also her time working at the Geneva Center for Autism, where she saw firsthand how autism and mental health intersect. Shortly after this day, Mojan and I started working together in a knowledge translation course, which is when we met Elena. Having an autistic brother who has been through his own mental health journey, Elena shared our passion for mental health and autism research. Together, we started exploring how we could improve the accessibility of mental health services for autistic people, building connections with organizations in the community and our networks, and presenting those initial findings. It was around here that Katie, another TRP student, reached out to us. As a social worker and a caregiver to her cousin with developmental disabilities, Katie was also eager to join. It was these lived experiences with mental health and autism, our personal and professional ties to the field, and our diverse skill sets that brought us together for this project to make an impact. Hello, everyone, and welcome to our capstone presentation. Thank you so much for joining us, and we are here to present the Meaningfully Empowering the Neurodiverse Initiative, helping autistic adults in the Greater Toronto Area express their mental health needs. Like I just said, this project has really been 2 years in the making for us, and we're really excited to finally be able to share this work with you. And also just a disclaimer moving forward that we will be using identity-first language, so autistic people.
So for today, we are going to talk about a bit of our agenda, followed by the issue and the goals we found. Then we'll jump into our methods, the key findings we had, both before and after co-designing our toolkit, and wrap it up with our impact and next steps. But before we jump into all that, in case you don't know, TRP or Translational Research Program, in this program, we are trained to be the bridge between the discovery science and patient care. In our second year, we do a capstone project on a specific population's health need. We then work with that population to address the need we identified together. And if you haven't guessed it already, the population we choose are the autistic adults. But what is autism? Autism is a neurodevelopmental condition, and based on DSM-5, is characterized by having repetitive behaviors, routines, difficulties with social interactions, and verbal and nonverbal communication. Based on the latest statistics, 1 in 50 Canadian children between the age of 1 to 17 have official diagnosis. So one of the first things we did for this project was to do a literature review. And we found out that in the mental health area, autistic people have higher rates of mental health challenges compared to the general population, including high rates of depression, anxiety, and suicide. As you can see on the left, 70% of the autistic population have at least one mental health condition compared to the 25% in general population. And based on the 2017 Canadian Survey on Disability, 84% of the autistic population above the age of 15 and above the age of 15 were rated their mental health worse than very good, compared to 34% in the general population. So seeing those statistics, we reach out to autistic adults and other relevant stakeholders through informal, semi-structured interviews. We ask about their mental health experiences and the challenges they faced when wanted to disclose their mental health care needs to their providers. And after that, we noticed that despite an increased need for professional mental health support, autistic adults still have difficulties with expressing their mental health care needs to their healthcare provider. The providers can range from their family physicians, psychologists, psychiatrists, to social workers. So the research question we came up with was, how might we develop an intervention that helps empower autistic adults in the GTA to express their mental health needs to their chosen healthcare provider? In this project, empowerment means self-advocacy, self-confidence, and agency over one's mental health-related decisions. One of the main objectives for our project was to create an intervention mockup, and we wanted to measure its effectiveness based on our empowerment measures. So we want to see improvement in autistic adult self-awareness of their mental health care needs. 2, we want to see improvement in autistic adults' confidence in expressing those mental health care needs effectively to their chosen healthcare provider. And 3, we wanted to see increase in autistic adults' sense of control over their quality of life and well-being. Before we jump to methods, we want to really quickly say that being autistic and experiencing mental health concerns are 2 separate matters. And just like neurotypical people, autistic people can live without having any mental health concerns. With that, I'm going to pass it to Elena to go over our methods.
Thanks, Mojan. So our project took a participatory design approach that consisted of 2 phases. So in phase 1, we held co-design sessions to create a simple mock-up of an intervention with our Autistic Advisory Committee. And then in phase 2, we held focus groups to evaluate and receive feedback on this intervention. And throughout this project, we used the Toronto Translational Framework, which is a person-centered framework for understanding the current state and barriers of a problem, and then innovating towards a future desired state. And so the informal conversations and need analysis fall into the understand stage of this framework, and everything else we'll be describing now is the innovate stage. So once we received REB approval, we began recruiting our participants. And so this inclusion criteria was that participants needed to be 18 years of age or older, currently residing in the Greater Toronto Area, could communicate in English, could provide informed and ongoing consent without assistance from another person, and had access to a technological device and internet connection. And so we recruited all of our participants through snowball and convenience sampling, where we use like word of mouth, social media, sharing digital recruitment posters, and our connections with various organizations. But now when we dig into the actual methods for this project, so we first ran 2 co-design sessions for our Autistic Advisory Committee. So in session 1, we explored the perceptions and experiences of empowerment in mental health. And then in session 2, we created design requirements for the intervention mockup. And so based on these design requirements, we then brainstormed 3 potential intervention ideas using a round robin activity. And then with these 3 ideas in session 3, we presented them to our members and they selected which one they agreed was best based on the design requirements. And so using this feedback, we then developed the simple mockup of this one selected intervention idea. And so once that was created, we evaluated the intervention's effectiveness by conducting 2 different focus groups where we asked open-ended questions about how well the intervention would improve participants' self-awareness of, confidence in, and sense of control over expressing their mental health needs. And in both phases, all participants had the opportunity to participate through speaking, typing in the chat, or anonymously on a Jamboard that we had set up for them. So then in terms of data collection, we collected our demographic information in the consent form that participants received through REDCap. And all of the sessions were audio recorded and transcribed using Zoom's built-in transcription feature. For data analysis, we utilized Braun and Clark's reflexive thematic analysis to code and analyze the data utilizing in vivo. And then we also had 2 different sub-research questions for phase 2, branching off of our overall one, to analyze perceptions of mental health empowerment and then design requirements. And then a 3rd sub-research question for phase 2 to analyze the intervention evaluation. But now I'll pass it over to Abiba, who will discuss some of our initial findings.
So as Elena mentioned, the goal of our first session with our committee was really to understand their perceptions and experiences with empowerment when expressing their mental health needs. So through our data analysis, 4 themes were constructed related to this. So different definitions and understandings of mental health, the relationship between autism and mental health, factors that promote empowerment, and factors that impede empowerment. First, our committee expressed that there is no universal or objective definition of mental health, and that many people hold different definitions based on things such as culture, environment, and language. That being said, they did feel that there were some general factors that contribute to someone perceiving their mental health as more good or as more bad. So positive factors included having a support system available and being able to regulate your own needs and emotions. And negative factors included difficulty with self-awareness, so knowing what you're feeling and needing, and environmental and societal stressors. Our committee also stressed how autism and mental health are connected in different ways. One being that the ableism autistic adults encounter in society can lead to trauma that affects their mental health, and how many people turn to masking, which is suppressing their autism tendencies, to fit in. Similarly, the committee expressed that siloing of resources was a problem because you often can't find things if you are autistic and have a mental health diagnosis. And the idea of a feedback loop was also mentioned, as the committee felt their mental health symptoms could often exacerbate autistic tendencies and vice versa. The committee identified 6 factors that promote empowerment and 6 factors that impede empowerment when expressing their mental health needs. So some key ones on the left include having independence and autonomy in decision making, as well as clear information and expectations. And some key ones on the right include when people treat autistic adults differently based on misinformation or stereotypes, or people ignore or invalidate their needs. The goals of session 2 and 3 with the committee were to identify design requirements for an intervention that would help empower autistic adults to express their mental health needs to healthcare providers. And the 3 overarching themes we found corresponded with the human-centered design thinking concepts of desirability, feasibility, and viability. So desirability refers to features or characteristics that would make autistic adults want to use the intervention. So these included an accessible user interface and content specific to autistic adults, a Canadian and GTA context, and that captures the diversity of autism instead of overgeneralizing what the population needs. Interestingly, though, one committee member actually recommended avoiding habit-forming features as a default in the intervention. So that includes things like algorithms or automatic notifications, as that can lead to users feeling forced to interact with the intervention rather than being able to use it at their own leisure. So that kind of aligns with session 1 findings that autistic adults feel empowered when they have independence or autonomy in their decision making. Feasibility refers to features or characteristics that make the intervention feasible for the team to make and feasible for the end user to use. So key points here, our committee felt that they're often redirected to resources without being taught how to use them. So tutorials are really important, and that people are often excluded from resources if they have no official diagnosis. So foregoing that. And lastly, viability refers to features or characteristics for how the intervention can succeed long term. So here, committee members really emphasize the value of partnerships and how that's determined by the community's trust. So picking organizations related to autism and mental health is the best option. So after we came up with the design requirements, we internally had a brainstorming session to come up with 3 ideas to pitch to the committee. So those included a free autistic-led peer advocacy program through which autistic adults would be paired with autistic peer mentors to learn how to navigate the mental health system and communicate their needs. An online resource toolkit that would serve as a one-stop shop for adult-specific autism and mental health resources in the GTA, including things like worksheets and instructional guides, and an online module that would give autistic adults comprehensive resources and info on how to express their thoughts, feelings, and mental health needs. In session 3, we asked what the committee liked, didn't like, and thought was missing from each idea. And then at the end, we asked them to rank their ideas and explain the rationale. The committee reached a consensus that the online resource toolkit would be the best option based on factors such as the feasibility to prototype and implement given the scope of the project, the ability to account for autistic diversity with different resources, minimizing ethical issues like liability concerns and privacy, and promoting autonomy once again. And despite this consensus, the AC did suggest integrating elements from the other 2 ideas into the idea here. So, for example, they wanted us to incorporate the social or peer element of the advocacy program into the resource toolkit through the addition of a form moderated by autistic adults.
So now we'll give just a brief overview of this resource toolkit that we created on Canva, but it's meant to simulate what the website would look like. And so this would be the top of the homepage with the various accessibility features that'll be consistently be at the top. And then when you scroll down, these are the different resource categories that people can access. And additionally, if you hover over with your cursor over any of these categories, a brief description of each would appear so you kind of know what you can expect. And so next, this is an example of what one of those resource categories would look like when you click on it. So you can navigate to see the main topics, the subtopics, and then the individual articles and resources for that category. And then we have the social forum section of the toolkit. So this is where people can communicate with others about any of the topics on the left-hand side and general things. And users would also be able to see the individual discussion threads and comments. And so as part of our deliverables, we created a video walkthrough that goes more in depth about the features and content present on the website. But now I'll pass it over to Katie, who will go through the results of our focus groups when we shared this toolkit mockup with our participants.
So after analyzing data from both focus groups, we identified 5 main themes that helped in the evaluation of whether this intervention is successful in empowering autistic adults to express their mental health needs. So these include desirable current features, additional suggestions, self-awareness of mental health needs, confidence in expressing mental health needs, and sense of control over expressing their mental health needs. Through evaluating the first iteration of our intervention with these focus groups, we better understood which characteristics were enjoyed. These features that continuously were deemed important were safety and security features, a customizable user experience, and the importance of autistic site admins and diverse moderators. There was also a number of additional suggestions to improve the intervention that arose through our evaluation. These suggestions revolved around the importance of differentiating this intervention from those that already exist and avoiding association with resources that participants did not have good experiences with. Along with these suggestions, additional recommendations included accessibility features, design features, and a service directory to make the intervention easy to navigate. We wanted to measure the intervention's potential to improve autistic adults' self-awareness, self-confidence, and sense of control over addressing their mental health needs. So there were many aspects of the intervention that participants felt were positive contributors to these set goals around mental health. These included content written by autistic adults, tools to prep for healthcare visits, actionable items, and how-to guides. Most importantly, participants appreciated that information would be centralized within this intervention, which would make it easier and quicker to access. Along with the positive contributors, there were also some negative aspects of the intervention that could be improved. The main feedback being that the intervention was not developed enough at the time to evaluate the potential for it to improve autistic adults' self-awareness, self-confidence, and sense of control over addressing their mental health needs. So an interesting observation we had is that people diagnosed as adults seem to find the intervention more impactful on their perceived self-awareness and confidence than those diagnosed in childhood. The former group noted that this intervention would have helped them make sense of their needs and validated their feelings, while the latter group believed that most autistic people are already aware of their needs. But despite this observation, both groups agreed that this intervention is a great starting point for finding resources in a Canadian context. And this observation prompted us to reflect on the composition of our Autistic Advisory Committee, during which we noticed from the transcripts that all of our members were actually diagnosed with autism during adulthood. Through the project, we found that autism-focused research has often left out the viewpoints of autistic individuals from study designs. This type of exclusion has ignited the nothing about us without us sentiment in the neurodiversity movement, which promotes the inclusion of neurodivergent individuals in all areas of the research process when such research is about them. To embrace this, we employed best practices in autism research and consulted with our project advisory committee who have expertise in autism research. This project and intervention are meaningful and impactful for a group of people who have been spoken for and over for far too long, so it was really important to us to do this work in a way that emphasized and put forth their voices and experiences. The next steps for this project are to start by securing funding to adapt this low-fidelity prototype into a full-scale intervention that's ready to be accessed by the public, and use this funding to hire autistic moderators to arbitrate once we're in that stage. Next, we will continue to network and collaborate with individuals and programs that can aid us in launching in a full-scale intervention. And we're also currently participating in the Nowly Press Start CoLab program, which is an accelerator for mental health innovations that we hope will help support the launch of the resource that we have created. Lastly, we want to acknowledge all the important people who helped make this project what it is today. These people donated their time, energy, and expertise to aid our team in creating something truly special. We'd like to thank our supervisors, Dr. Joseph Fehrenbach and Dr. Edita Marcon, for their continuing leadership and support over the past 2 years. We would also like to thank our PAC committee, Dr. Joanna Lake, Dr. Mackenzie Salt, and Dr. Tim Ross for their guidance and expertise over the duration of this project. Next, we would like to thank Dr. Chris Klinger and Dr. Raza Mirza for their help in the starting of this project and adopting it to the model that it is now. Lastly, but most importantly, we would like to thank our Autistic Advisory Committee for co-designing this intervention with us, as well as our focus group participants for teaching us more than we ever expected from their personal experiences and perspectives. We would not have been able to do any of this work without all of you. Thank you again so much, and thank you for coming to our defense.
Thank you very much. It was great. So now we have time for questions. So I will go to the advisory committee first. And I'll start with Joanna. Do you have any questions?
Sure. First of all, congratulations. Wonderful, wonderful presentation. I know how much thought and energy and creativity and all of the things went into this project and into this presentation. I think you did a really great job of bringing a lot together in a really concise and informative presentation. So thank you. Okay, my first question is, how do you think you might adapt this kind of a tool, so the toolkit, if you were thinking about this as like a next step for autistic people who might have like a co-occurring intellectual disability, or even thinking about autistic children and youth? Are there considerations you might have around how you might make the tool more user-friendly for those groups?
Yeah, thanks for the question, Joanna. I'll take this one first. So I know that when we were first developing the project and doing our need analysis, the idea of do we factor in intellectual disability or not was something that we wanted to consider. And because in the research, there can be some differences that autistic adults, for example, with intellectual disabilities may face versus those without. And so for this project right now, we didn't take into account those differences, but it would definitely be a next step to see if there are any additional modifications or adaptations that we could make to this intervention in order to cater to any specific needs that those individuals may have. And the same goes for autistic children and youth. But really, we focused on the autistic adult population just because of the scarcity in resources that we identified.
Great, thank you.
Joanna, do you have more questions? We can do 2 questions each and then move on.
Sure. Yeah, no, I do. Sorry, I'm new to being on a committee.
Well, we
So,
also change it up so not to be the same all the time.
no, it's good. Okay, another question I have is, if you were, so let's say like thinking into the future and you're actually like now implementing this in the community, this is being rolled out, how do you think you might evaluate the successful kind of implementation of whether or not the tool is being used, if it's helpful to people? Like, are there some thoughts you have around how you might assess those kinds of things to really understand if this is in fact helpful to autistic adults around those different objectives you had?
Thank you so much for bringing that question, because it is something we thought about and actually talked about it with our AC committee and focus group. So one idea we had was to add, like, we have this feedback option at the end of each section, all about like pages and each section, so they don't have to, when I say click on the feedback, they don't have to be like, oh, I'm talking about this page. No, each feedback link we are planning to be specific to that page, so people can tell us, is it useful? Is this page useful? If the information is useful, would you like us to add anything, remove anything? What are your thoughts? And we also have like moderators we're planning to have moderators for each of our forums. So like each topic has like assigned moderators. If they observe anything, or if people can also reach out to them for feedback. That also is like something we added. And I think we had for the feedback was people can add articles to it, or like their own bit of personal experiences, because we've got feedback that how it's important for the autistic voice to be heard and have the opportunity. So we're like, okay, why not add it to this feedback section as well? Yeah, I hope that answered your question.
Yeah, that's great. I think the idea of having people be able to give feedback in the moment while they're using it is really a great idea. And then you can kind of use that feedback to, adapt things you can sort of according to it. So yeah, and I think the idea of the moderator, that's really, really brilliant. Thanks. Great answer.
Thank you. Tim, do you have any questions?
Oh, I do. Yes, yes. First off, thank you all for the presentation. I found it engaging, informative, and I thought you provided some really useful context about your program, and I quite liked how you opened it up with some talk about your positionality and how you relate to autism. I just thought that set a nice context. And I mean, I just come away from the presentation really appreciating the level of effort, detail, general thoughtfulness involved in this work and how remarkably process-oriented it was. So let me think. I think I'll start by asking, I'm curious about your engagement process. And I'd love to hear a little bit about what you felt worked really well so that we can think about, maybe that's something we can use in other studies, but I'd also love to hear about what you feel like didn't work so well. And maybe if you could change something about that, what would you change?
Yeah, I can take this one. Something that we found really worked really well, and we've kind of implemented with this defense as well, is using a Jamboard. We found that having a method for individuals who are in focus groups or in co-design sessions to participate anonymously really encourages people to get like their initial thoughts or ideas down. And then I think it also opens up the floor if something's said on the Jamboard, people are more likely to actually like talk about it verbally in discussions as well, because they're like, oh, everyone's already seen it. It kind of reduces that like initial anxiety. So we found having a Jamboard and having like people be able to like, oh yeah, like someone wrote that and I want to add on to that. It really fueled engagement there. Um, Another thing is I think having the option to have your cameras on and off. I know that's something that's like, historically people who have been in lectures during Zoom know that like turning your camera off is like a sign that you're not engaged. But I think for our participants specifically, being able to have their camera off made them more comfortable. And especially because we also implemented something Mackenzie suggested, which is using avatars as well. So people had
Right.
the option to turn that on and it emotes, but it's not really their face. So that also minimizes anxiety. One thing that wasn't as smooth as we hoped is after every session and after the focus groups as well, we sent out a feedback form to be able to, make changes with the next sessions or, just gather what people liked about how we ran it, what people didn't like. And we would send those at the end of the sessions. And to be honest, the amount of people who completed it was like abysmal. Like one or two people would complete those feedback forms. And it was really helpful feedback when we got it, but I think maybe giving time at the end of the session itself so people could fill it out would have been a better way to make sure that people are engaged. Because I think just sending it afterwards was like people were like, okay, the hour's up, it's time for me to leave. But yeah, it was helpful when it was completed.
Okay. Thank you very much. That's great. One other thing I'll ask about, I mean, just given that you opened the talk where you're chatting a little bit about your different positionalities, were you reflecting on this throughout the process? And if so, how did that take form? Or were you were you practicing reflexivity, doing activities throughout the process before or after? I'm just curious how that got folded into the process a bit.
Yeah, can I just clarify, are you saying like our experiences before we got here and how that impacted like what we did with our project? Is that what you
Well,
mean?
I mean, that's part of it, but also how you are relating to participants, their input, thinking about the power dynamic that's at play, just reflexivity in a very broad sense, I suppose.
Yeah, I can start with this, and then if my team members want to jump in. I think it was really important for us to kind of, put ourselves in other people's shoes in the plainest terms with our participants, is trying to understand what they would be experiencing from the other end of our cameras when we were interacting with them. So what would make them more comfortable? Oh, if I was in this position, I'd feel more comfortable if I could do this and this and this. And then we tried to implement those things throughout our project, which we still continue to implement, like the Jamboard that we set up for today, and asking our participants, how do we want the information to be shared? What is the best way to share it with you, and things like that. But if I'm not answering your question, please let me know and I'll try and restate it.
No, that's helpful. I guess I'm just thinking about, given the work that you're doing and you're producing these outputs through, the co-design, the input with the input of your autistic participants. I guess I just wanted to ensure you're really keeping that in mind and kind of challenging yourself and your ability to represent their voices and trying to implement as many measures as possible to make sure you're doing that. So thank you. I appreciate it.
Thank you. Mackenzie?
Are we only doing one round of questions or two?
No, we can do definitely more round of questions.
Okay.
We're just trying to make sure that everybody has a chance to ask, and then we're gonna go back around.
Okay, great. Because I have a bunch and I wanted to see which ones could go and which ones couldn't. I had a question based on, I think I know the answer based on your presentation, but I didn't really see it in the report. But I'm curious, how diverse was your sample from an autism spectrum standpoint? Did any non-speaking people participate?
No, we did. That is one of our screening questions, but no, we had most individuals participate who could participate verbally. Yeah.
Okay, and did any of the lived experience partners, consultants, anybody make suggestions for the tool on behalf of people or groups that were not represented in the consultations?
I don't believe so. There are general questions, especially in the focus group. We had a really good discussion about sort of like intersectionality of various people's like lived experiences when it came to using this sort of intervention. But I don't believe anyone spoke on behalf of another individual if they weren't living that certain identity themselves.
Do you feel that based on that, do you feel that you might have encountered any sort of lateral ableism in those sorts of interactions?
That is potentially that could be. It didn't jump out to us that we have experienced that, but I know that it is definitely prevalent, especially like people who are still on their journey for like self-acceptance or even just like learning about themselves. But no, we didn't encounter any lateral ableism or like ableism in general, interestingly.
Okay, thank you.
Thank you. Doug, you have any questions? You're muted.
My answer to your question, editor, was, oh yes, I have a few questions.
I know. This was
as-
kind of a rhetorical question, I guess.
Yeah, as you and Joseph know. Well, first of all, I'll join the everyone's happy kind of vibe around here now and say it was a good presentation. And I'll immediately start playing the bad guy, as Joseph and editor know that I will, because and I will say this both as I would say a longtime academic and also a representative of SGS here. I tend to approach this as more than a term paper in a project course, and a little more like what should be, let's say, a master's thesis for a master's degree from the University of Toronto. So I understand that you're allowed to present it this way. I felt that a lot of my problems with it might have been addressed if you'd presented it more as a written academic report rather than a series of PowerPoint slides. So a lot of my questions might have been answered in a more rigorous and referenced report. but I suppose I really have questions in 3 general areas. And since we're doing a second round, maybe I'll just ask 2 of them first. And my first concern, I suppose in no particular order, my first concern was about, how unique is this? And this is where I would have liked to have seen a nice introduction, a written introduction, well referenced. And I'll just say as an aside, your references are rather slim, and I don't think you proofread them. That a well-referenced introduction that could have looked at who else is doing this. I don't think Toronto is unique in having a population of autistic adults who need help navigating a healthcare system. So for any original contribution here, and I just quickly Googled help for autistic adults in Boston, another healthcare system that we in Toronto hope to rival, I suppose. And I immediately found, pages of references about help for autistic adults in Boston, the Autistic Spectrum Center, the Lurie Center at Mass Gen. And these are all well-established long-term programs that have, not only a lot of experience in guiding autistic adults through navigating the healthcare system, but have published work in that area too. So I would have liked to have seen some knowledge, acknowledgement that this is kind of a, it's an established field. And with that comes, not to discredit your work, but with that comes the obligation on your part to tell us what contribution this is making. And maybe the contribution is only locally. That would be a little disappointing to me. But that is one thing I would like to see addressed. And I guess another big issue for me then is the sample size. We always come back to sample size. But I mean, gosh, I guess your meaningful results are in the phase 2. You got 6 autistic adults. You must have had a big population to sample here in Toronto, and you could have got more meaningful results from a larger population. I thought, well, maybe there were problems in recruitment, but then I noticed that you address the recruitment issue by saying, well, actually wrote it down, what you say, recruited by word of mouth and easy access. Wow, just think about the biases built into that, huh? I mean, are you worried about that? And then, I mean, maybe I should stop and let you address a couple of those points. I have another big one about that goes on about the characterization of the demographics, but I can save that for another round. So maybe you can respond to what I've said so far.
I can try to attempt to answer some of the points. Sorry, as you were talking, I was just taking notes of the parts of the questions. But so like it was a concern about like what are the existing resources and how we are unique. Then there was a recruitment portion of it, like how it was we recruited people and maybe there was an issue with it. That's why we had a small sample size. And of course, the last point was about sample size, correct? Am I
Yeah.
summarizing it well? Okay. So I can just quickly
most of it, yeah.
Yes, thank you. I can quickly share my screen again, since we do have some backup slides for this. So while it was our first time hearing about the Boston one, resource for the autistic adults, these are also some of the other existing resources. One is pretty well known as the Aspire toolkit, which is based on US. I can try to make this bigger actually. There we go. So one is called the Aspire toolkit, which is based on US, and the other one is Aid Canada. So maybe, let me start with the Aspire one. So Aspire one has been something we've been hearing from the autistic community themselves and from some of our professional stakeholders. And I was able to kind of connect with one of the creators of the Aspire, so Dr. Christina Nicolaitis. we were able to connect, and she was like kind enough to say how we can go over her website that she created and see if there's any topics we like and potentially have a partnership in the future and work collaboratively. And they also introduced us 8 candidates about the website, and we were like, okay, after searching up these two, and we actually introduced the Aspire one to our AS directory, and they really like the features it has for the Aspire one. They like how simple it is, it was easy to navigate, and the topics it had was useful. But one comment we got is that while some of the worksheets are useful, like whenever you're in US or Canada, some of the other topics on how to navigate the healthcare system was United States specifically, which I assume will be the same one as the Boston one that just came up in your search. So one thing unique about us was we want to focus on, right now it was a GTA, but maybe broaden off to the Canadian contents. But you might ask, there is 8 Canada right here that is in the Canadian contents. And it has a lot of resources in it, not gonna lie. But when we introduced this to our ACE direct, like advisory committee, they found that it gears more to all children and caregivers. And sometimes it has like the attitude of wanting to like find a cure for autism. So and it was very hard to navigate the stuff in it. So our autistic advisory committee was like, well, some of the contents are useful. It might not work best for us as autistic adults who wants to address their own mental health needs. Before I move on to your other points, does any of my members in the team want to add on to this one?
Yeah, I was just going to add that a lot of the existing resources are specific to autism or specific to mental health. It's hard to find resources that are crossovers. And also, one of the important things that we found with our Autistic Advisory Committee is the importance of the social interaction with other autistic adults, which they get through the forum that would be created. So that's unique to this intervention as opposed to others.
It would be nice if you could document that. I kind of, from what I just quickly read about some of the Boston programs, that's not particularly unique in wanting to, get cross connections between the patients and so on. But my suspicion is that I could have searched New York or McGill or anything and come up with various initiatives. One angle that you might take on that would be the uniqueness of the Canadian healthcare system versus, let's say, the US, where a lot of the big programs seem to be. But I'm sorry, I'll let you go on to the next point.
Thank you for that. And as for our sample size, I'm pretty sure we had, yes, sample size unfortunately was one of our limitation, and that was like specifically due to the scope of our project and the timeline we had. Again, we couldn't really start a project without getting the REP, and after receiving the REP, we only had like 4 to 5 months to finish this project due to like various reasons we had. So even though we had like only 12 participants, AAC and focus group both completed, we tried to make it as diverse as we can. And I can show you some of the demographic. We try to have like various gender identities, racial identities from both like phase 1 and phase 2. And another thing we also counted for like sexual orientation and age distribution. But again, in the age distribution, you might see is not as diverse as we hoped for. Another thing we want to address for this one is that while our recruitment channels from the participants we got were from various recruitment channels, they somehow ended up being in the same age range. We thought 2 possible things for it. One was that one of our requirement inclusion criteria was they have access to Ethernet and like a technology device to potentially have these meetings online. And another one was that most of our recruitment was done through newsletters or like digital media rather than having physical posters in places. So that might have been one of the reasons why it ended up being like this.
The one thing that sort of surprised me was that you would. I understand the time limitations and having to go through the ERB and the REB and everything, but I was still surprised you couldn't get a lot more than 12 initially. But my point here is that the smaller the sample size, the greater the risk of bias. That may not be a statistically valid comment, but it stands out here. And you know, why did half of your participants drop out after phase 1? And one thing that stands out, just as an example, is that it looks like you only have one heterosexual remaining out of 6 in stage 2. I wonder what kind of discrimination or bias led to that rather unrepresentative distribution. I don't know that there's a lower range of heterosexuality amongst autistic patients, although this is far from my field. Just an example of the kinds of bias that might be creeping in with such a small sample size.
You're definitely correct. And just to, I think I did not communicate correctly. So phase 1 was our autistic advisory committee. So those group was separate from phase 2, which is our focus group members. So it wasn't really a drop. It was just like different groups of people.
Okay, so the actual autistic patients are those in phase 2 only.
No, phase 1 as well. So we had 6 autistic advisory committee members in phase 1. And in phase 2, we had 2 focus groups. And in those focus groups, each of the focus group had 3 autistic adults. So
okay, I've got it. So phase 1, 6 advisory, 6 autistic, and the 6 autistic stayed into phase 2.
So it's different 6 autistics.
There are
A different
12,
6.
there are
Okay.
12 autistic adults in total, but there
Yeah.
is no overlap between the participants in phase 1 and phase 2. They're 2 separate groups. So
Okay,
6 and
why
12.
would that be? Why wouldn't you include them all in the
Because we wanted to make sure that if we're co-designing an intervention with one group of autistic adults, that we're testing it with a separate group. Because if we co-design something with that group, they're
Okay, I
obviously going to
got
be
it. Yeah,
biased about
that
it.
makes sense. Yeah, and I think you might have said that in the report, but it didn't quite register with me. So okay, yeah.
I
Thanks.
also just wanted to add on, I know there was a comment about how the report could have been presented in a more academic way. And I just want to clarify that even the way we're presenting our slides right now is built for autistic adults. The audience for the report was autistic adults. We asked our autistic participants, how would you like the knowledge from this study to be disseminated? What do you want to see? And so they responded to us and they said, we want a visual report. We want a tutorial on how to use the toolkit. We want it to be something that's engaging and not so academic, but we also want to be able to see like a shorter version and a longer version, which is why we have the 2-page summary, which is why we have the walkthrough, which is why we have the visual report. It's all for the population, including this presentation, which actually some of our participants are attending today. So I just wanted to make that clear.
Yeah.
I know it's not the traditional thesis approach, but this is not a traditional program.
No, but it might be helpful to the examining committee who are deciding the value of this for a master's degree at the University of Toronto to have seen your presentation as an appendix to at least an introductory academic presentation. But I realize that's not a requirement of your program. It's just that's a comment more to Joseph, I think, than to anyone perhaps, but because I've made it before. Okay, thanks. I have one more question and I'll wait till the final round. So that's good.
Thank you. And this is like, this is why I really like when Doug is here at our defenses, because certain things are coming out and, and you guys have a chance to defend it, and to point out your point of view. So thank you. Jessica.
Great, it's my turn. Great presentation. It's always very refreshing to join TRP presentations. I do miss them. So I was actually very intrigued by your finding that people who were diagnosed later in adulthood versus those diagnosed in childhood had different perceptions of their perceptions of how the autistic community dealt with communicating their mental health needs. And I was wondering if you found any literature in your literature review, if you did any kind of reading after your findings to interpret them, if this finding was supported by literature out there? Because I just thought that was really interesting.
I can really quickly comment on that. And we want to say it was more of an observation than a finding. That's why we didn't our findings. Again, our sample size was too small. And if we only noticed this one as we were writing the report, we were like, wait. And then we checked the transcripts again, because in our recruitment surveys, like interviews, we asked if you have autistic, like official autistic diagnosis. We didn't ask when you got the diagnosis. We didn't, at the time, we didn't think it as significant, but as we went through, we're like, oh no, it seems to be very significant when you got the diagnosis. So based on, just to give you some numbers, all 6 members of our autistic advisory committees were diagnosed in their adulthood. While in our focus groups, we had like 3 people that were diagnosed in adulthood and 3 people diagnosed in childhood. And that's how and coincidentally, all the people that were diagnosed in childhood all ended up in the same focus group. So our session with them was vastly different than what we had with our other focus group. We were like, oh, something fine.
Yeah, no, that's kind of like that's an interesting I mean, it's an observation obviously at this point. It wasn't the initial purpose of your study, but I would highly encourage you guys, if you wanted to extend this project with a larger sample size, to investigate that difference, because I thought that was pretty cool. Brings to show how important it is to have an early diagnosis, right? Because the earlier the diagnosis, the better you are supported in communicating your needs, I would presume, I would hope. So my other question for you, and I think that there was another committee member, I think it was Mackenzie who brought it up, regarding the nonverbal communication in your the demographics of your participants. I was curious to know whether you asked about any particular needs of the participants, with regards to their autism. So whether that be sensory or communication style, etc. Whether you kept record of any of these particular characteristics, and whether you think that would play any role in how people interact with your tool.
Oh no, I think I messed up the order of us answering questions.
I can take it. Yes, we took notes of things like this, we didn't specifically ask, do you have these things that you need accommodated or what have you, but we did take note when we were talking initially with our participants about what would make them comfortable. So that was helpful for our information. And adding things to the toolkit that made it accessible all came from information from our participants that said, maybe I need this to, I don't know, maybe the font sizing makes it easier for me to read, or maybe different colors, what have you. So all of those came from our participants with our co-design to, try and use what they need in our intervention, if that kind of answers your question.
Yeah, I guess in that sense, it was an indirect way of asking people what their needs would be, or how their needs could be accommodated in the design of the toolkit. If I've understood correctly. Okay.
Yeah, if I could just add on to what Katie had mentioned. So when it came to participants participating in the sessions, if that's kind of also what you were leaning towards, we did ask if there were any certain accommodations that we could make for them during these sessions to make them feel more comfortable in participating and attending. And this also comes back to some of the best practices that we wanted to incorporate. So informing people that they can have a support person nearby if they wanted that. Promoting the use of any fidget toys during the sessions, turning cameras on and off. And so having those best practices while in the co-design and focus group sessions. And then also with that, these are some things that we can incorporate in the toolkit for various accessibility features, even in tutorials that we plan to have in the toolkit that maybe go through how to use the social forum, for example. Those would have a transcription and captions and all various sorts of things.
Okay, great. Thank you. I think that's it for me for now.
Sorry, I'm saying thank you and I'm muted. Thank you. So we're gonna do one more round of questions from the committee. We're gonna do one question this time each, just to make sure that we have time to go around, and we'll see if we have more questions after that. So I'm gonna go back. I'm gonna do the same order if that's okay. So Joanna?
Sure, thanks. So do you anticipate any sort of sustainability issues with the toolkit? I know you kind of alluded to like potential funding in the future, like thinking about like how to maintain the forum, update the content, that kind of thing. So thinking about what sustainability issues might arise, and then also thinking about like how would you address some of those things, if you could.
Yeah, that is something we thought about in our next steps. Funding is crucial to this project in its length and timeline, and if we don't have that, we're not able to essentially hire autistic moderators who would upkeep the information on the website, or I don't know, help us in creating new things for the website or talking to people on the forums, which is super important to us because that was one of the things that was deemed as significant, was that we needed to have autistic adults moderating. So that funding would be really important. Do you mind just repeating the end of your question so I can get to that too?
Yeah, no, it's already a great start. I was just saying if you were thinking about any issues that might come up around sustainability, and then how you might address things that could arise, that how you would help sustain some of those different aspects, I guess, of the toolkit.
Yeah, I think the one thing is the funding is the most crucial thing that we have, is if we can't get funding, we can't continue the project. And the way that we get that is apply to more funding. I guess that's the way to figure that out. We have been, and hopefully we do secure some funding so we're able to continue with this work. Mojan, I see your hand is up.
Just to building on what Katie said, after like securing that funding, hopefully we are also planning to reach out to the people who already have like similar toolkits in other places, and our best start will be like one of the co-founders of the Aspire website, where we already have the connection. They're just on sabbatical right now, so we have to just wait for them to come back and ask them about how to run this. And they also mentioned to us before that it is a bit on the trickier side, especially for the long-term plan. That's why we want to secure funding and creating that initial team. And we are hoping to have them all being autistic people. So that also like makes it more authentic. How you pronounce it, that word always gets me. But yeah, so that's the plan. We want to create like hire people that actually cares, and so they can run it in the long term. And we also still need more help on how to keep the information updated and who actually has access to it. So I think the broader answer will be we don't really know how, but we know the first step will be to connect to those who actually know how it's done and get more feedback from them. Does anyone else from my team want to add anything to this point?
I can just add that I know we touched on it briefly, but I am on behalf of our team participating in an innovation accelerator. So it's run by this insurance company, and they have a pool of $70,000, and they allocate it to mental health related innovations that are youth, so run by individuals that are 18 to 29. So we fall into that category. Thankfully, we're still young, but we're trying to get funding through that. So it's a 10-week program. Every week is like, pitching stuff and working with different mentors in the mental health space. So we're really learning a lot through that. And I think honestly, we have a minimal viable product. We have, stuff to back up the fact that we have this minimal viable product. So I really am confident that we'll be able to secure at least like the maximum funding from this program, which is $10,000. But it's really about, making sure we have things like a web developer, making sure we have those autistic moderators, but also the team to build, the content, but also, how do we upkeep the content? So yeah, just wanted to touch on that.
Yeah, I think that's great. And I think it's smart too, because it's true. There's lots to learn from these other groups and tools that are out there. And I think you're right. There are different ways to do it, right? Grant funding, nonprofits. If you could, the tool could become affiliated with a hospital, like a mental health program or hospital or service. Because yeah, I think that the ongoing funding piece will be important to ensure that people's time is valued and people's voices are heard, and then you said like the quality of the tool is maintained in some way. So yeah, sounds like you've already got some fantastic ideas. So exciting to hear that it will continue on in some way.
So if when Abatha finished, I think Katie said something, but she was muted.
No, I was just agreeing with my team,
Okay.
but thank you.
Thank you. Tim?
Thank you. I just wanted to know one point that Doug had made, just with respect to emphasizing the uniqueness of what you've done. Uh, I do wonder if there might be. I think it might be nice to have something in the report that speaks to that. I mean, you've put the work in, the Canadian context. It it does make sense, and it kind of aligns with what we're doing here in academia. Even though you've got a, we're aware it's a unique program, but I just think it might be nice to acknowledge that. That's not what my question is to do with. I want to know to what extent have you considered accessible document features in the report two-pager, alt text reader, page navigation? Is this something that has been considered or will be considered going forward?
Yeah, I think especially as we continue to develop this idea in the intervention, creating, sorry, I thought I was muted for a second. So ensuring that we are creating different accessibility formats, like we have the video walkthrough with the tutorial, with the transcript and the captions, but again, like you said, like having these different features in the actual written up reports is important. So in future iterations, making sure that we are achieving that, and then even disseminating what we have currently, if we're planning to disseminate it widely, that is something that we can create.
I ask this because I do find that there's an ableist practice where we seem to gloss over, we finish a document and it's all done, but we ignore the accessible features. And I think we've got to find a way to veer away from that and start to bring that forward in the process. Can I squeeze in one quick question? I think it's a quick answer where I don't see it. Okay. Uh, I was just curious. I wrote down Nowly Press. What is this program? What was it, and what does it do?
Nowly Press Start collab program. I know it's a
And what was
mouthful.
this is someone you're
Yeah,
going to
so
partner with or hoping?
no, so it's the innovation program that I was just talking about. So
Oh,
Nowly itself is an insurance company for teachers, I believe, but every year they have this innovation accelerator program, which is specific to mental health innovation. So people often come with ideas, people come with, minimal viable products, and it's all about working in this program for 10 weeks to kind of work like refine the idea, get advice from mentors who have actually started things in the mental health. Like a lot of the people there are like startup founders. So getting more advice and then pitching your idea at the end to try to get grant money. So they have like $70,000 as a pool and they allocate it to 7 projects. So $10,000 each.
gotcha. Okay.
Yeah.
Understood. No, that seems like a logical path forward. Okay.
Yeah.
Thank you.
Thank you. Mackenzie?
Thank you. Okay, so I'd like I'd like to build off of Joanna's question a bit and think about implementation. So one of the priorities that was identified in session one or phase one was that the tool would include a social or support system to allow people to connect with others, share information and experiences. However, when the tool goes public, there will not immediately be a social system in the tool as no one will have signed up for it yet. So do you think that could could that hurt the feature or the rollout of the tool? Do you have any ideas as to how you could increase uptake in this feature initially, or whether that would be necessary?
Team, sorry, we have an order of who wants to answer questions, but I think I messed up the order. So if anyone wants to jump in, feel free to jump in. Otherwise, I can tackle this question. All good? Okay, so that's a very good point, like that you just brought up. Not gonna lie, I haven't really thought about that first a few weeks or month of this being out. So, but I was thinking we do have the moderators that are already hopefully hired by the time we launch this forum. So even if someone like aside from the moderating team finds it and interacts and posts stuff, the moderators can like reply back to them. So starting that social. And I was wondering, something we can do is when we advertise it, we kind of advertise it with this social forum as well. So the communication team for that, I think, will be key to like say we have this feature. There is somewhere that you can socialize and talk with other autistic people and get other information. But that's how I'm imagining it, just like right now thinking about it for the past 1 minute or so. Does anyone from my team have any ideas?
I can just add that, yes, we will have moderators, and the point of the moderators is to post on these forums. So if they're posting before this goes public, then that is still an aspect that's being promoted and interacted with. But for sure, it could hinder the rollout of this intervention. That's not something we've really considered before right now. So that's a really good point, and we will have to think about that.
Okay, thank you.
Sorry, thank you. I'm muted. Doug, do you have another question?
Yeah, I'll make this my last one, but it might be a little bit expansive, but it focuses on one thing. And that was, I guess I was kind of alerted to looking for more information when I saw the comment on one of the slides, and it was reported here today as well, that I'll just quote from the slide: autistic adults experience a higher rate of mental health challenges. And I said, well, yes, of course. But autism spectrum disorder is itself classified as a mental health challenge. So beyond the semantics of that sentence, I'm sure that the team is aware that autism spectrum disorder is classified by ICD-10 as, I think, 84.0, and the DSM-5 recommends that any diagnosis be accompanied by any other complicating diagnoses. Common ones, and my sense is that your cohort doesn't experience any of these more severe ones, but common among them are Brett syndrome, Down syndrome, even ADHD, and these things should also be included in the diagnosis. And that got me thinking then, what I would like to see is a demographic table. Subject 1, Subject 2, Subject 3. ICD diagnosis, you've approved. Age at diagnosis, because you make a point of the adult diagnosis and so forth. And most importantly, I think, according to DSM-5, is level. And I'm sure you're aware of the classification of the criteria for level 1, 2, and 3. And again, my sense is that you have pretty highly functioning, pretty social media aware cohort, and they would all probably be level 1. But again, I'd like to see that in a table of the demographics, and that should also include, see that here's where I'm expanding my question a little bit, should also include other things that you've pointed out, let's say sexual orientation and race, because race or ethnicity or whatever you want to call it, because you've made a point of those in your report. But I'd like to see how that correlated to perhaps level and clinical diagnosis and some of those statistics. And becomes important to me when you start to talk about diversity. Because if I do a study, let's say, of a particular effect of a particular drug, and I have one male and one female, I can't comment on diversity. I have to have, 40 males and 40 females and see if there's a difference. So when you talk about diversity in your population, I would perhaps a bit controversially say that you have no diversity at all, because in many of the groups, you don't have a comparator. But again, that is information that should also be documented in a table of demographics that included clinical diagnosis, age at diagnosis, level of diagnosis, level 1, 2, 3, and other factors that we'd like to see. And that's pretty standard in any, I mean, if you were thinking about publishing this anywhere, you'd need that information as a starting point, right?
Comments from the team?
Yeah,
Yes.
I wasn't intending to leave you speechless on that.
No, no, no.
Well, let me ask a question simply. Could
Yeah,
you provide that information? Could you
Yeah, I was
construct that table?
So we could definitely provide the demographic characteristics as we already showed. So things like the age of the participant, sexual orientation, ethnic or race. But when we put that observation on our slides that more of our participants were diagnosed in adulthoods, we didn't note it as a finding because that was something that came up in our transcript. So it wasn't something we actually collected in our demographic questionnaire, age at diagnosis. It was something that our participants mentioned in our transcripts, like I was diagnosed in adulthood or because I was diagnosed in adulthood,
Yeah,
which is
okay.
how we noticed that. So we don't have age at diagnosis for every participant. We just know the relative breakdown between adulthood and childhood.
Fair enough. So
Yeah.
the age that you list in one of the figures, the ages,
That's
that
age
age
now,
during
current age.
participation.
Yeah.
Yeah. Okay, I got
Yes.
that. That's fair enough. Do you have I'm sure you're aware of DSM-5's
Yeah.
classification levels 1, 2, and 3. Do you have that diagnosis? Could that be provided? I think that would be very helpful.
Yeah, so we did not collect that information. It's a good point that you brought up because obviously that will affect how effective this intervention is for specific populations with different needs. But our rationale for not originally collecting that information was we were considering it kind of like a barrier for people to participate because it's difficult to disclose that. I think historically people who are at different levels have felt different ways in research because inclusion criteria can often favor people of a specific level. And that's just something that's always happened. So when we were thinking about people we wanted to include, we included criteria like you can verbally communicate or you can communicate with an assistive device. You can have a support person because we wanted to keep it as broad as possible without having those barriers in.
Fair enough.
Yeah. Yeah.
But that's something, again, that I think a lot of readers like me would leap out at right away. Could you, because I'm going to ask, and your supervisors may not ask you to do it, but I'm going to ask for some kind of written summary to address some of these issues. Could you discuss why you didn't do that? I mean, I think you gave a reasonable answer, but it would at least satisfy somebody who was asking why didn't they include those data in a table or something, right?
Yeah, and that kind of leads on to what I wanted to add on to what Abitha was talking about. So we didn't ask for that information, one, because of that historic nature of participants being scared to disclose their diagnosis, not even just like the level that they were diagnosed with, but the fact that they do have an autism diagnosis as well. It's even a barrier for people who don't want to seek out a diagnosis, because with that, there can come with a bunch of other challenges, especially if they come from a culture or a background where autism is still seen as something taboo and there's a lot of stigma around it. But further on top of that is we didn't want to medicalize autism in any way. Autism is not, I know it is in the DSM-5, but it's not a mental health condition. And sorry, I'm getting passionate because it is very personal to me.
Why do you say that?
Yeah.
If it's in DSM-5, it's
I think that just goes
classified.
to show how much work that the medical field as a whole needs to work on in terms of dismantling the ableistic society that we currently live in. And so, yeah, that is a big systemic barrier that that was present. And even though it is in the DSM-5, there were things in the DSM-5 decades ago that are now not there because we've progressed further in society. And so this is just another one of those cases.
I would suggest that what we really have to overcome is having any stigma associated with the classification of a mental disorder. I myself was one time considered to have obsessive compulsive disorder. I don't see any stigma associated with that at all.
Yeah,
It may
and
have
there is
helped
no
me in my career.
Yeah, and there is nothing wrong with having a mental health diagnosis. I think something being in the DSM does not inherently mean that that's a bad thing. It's just the fact that autism is not a mental health diagnosis. So making sure that that misconception isn't perpetuated. And that is a misconception that we didn't want to promote in our work. And again, so yeah, there's nothing wrong with having a mental health condition, obviously. My brother, myself, has mental health conditions and autism. They're two separate things.
Yeah. But if you want to publish data like this on outcomes, you have to have, follow conventional classifications and things like that to identify your study group.
And you might, the other way of doing it, you might actually add a paragraph that explains what the two of you were just saying, because that's an important point. And to tell you the truth, that might be a white paper or an opinion in somewhere that's based on facts, which I would really like to see. And it might be one of those things that can go into the Health and Law journal that Gilbert is the editor of. We can put it as an opinion piece if you guys want to write it up. I think it'll be a good idea. Just putting it out there.
Yeah.
I just want to step up and take sort of, I guess, personal privilege, and I don't know if this is my head because I've been down with COVID as well, and in addition to the myriad other comorbidities I seem to have. But I want to ask the committee this specifically because in my funny state of mind, in my recollection, I thought this discussion was had and that there was actually a very specific
Joseph, I don't
choice.
mean to interrupt, but you're very muffled right now.
Yeah, difficult to
Sorry.
understand you, Joseph. It
It might be your mic quality.
might be your mic, yeah.
Yeah, we can't really hear you very well. You might want to write it up.
Better? Any better?
Yes, yes,
There now,
yeah,
yeah.
that's better.
Okay, so here's my apologies, I'm a little foggy, but yeah, I seem to remember that the committee, and this is to the team and the committee, I seem to remember there was a discussion of why you specifically picked level 1, very narrowly targeted individuals for the purpose of your capstone and intervention. And so I wanted to ask you whether that was true or my imagination, because I think that some of what Doug is bringing up here was a deliberate choice as opposed to an omission or an oversight. So were you looking at a particular subset of a population for this for your project or not?
Whether it was deliberate or opportune, Joseph, all I'm asking is if the cohort was all level 1, it doesn't invalidate any of the findings, but let us know that.
And yeah, that's what I'm saying. That's what I'm asking for, the rationale. If you did do that intentionally, what was the rationale behind it?
Yeah, so our inclusion and exclusion criteria were very specific and intentional because we didn't want to exclude anyone like along the autism spectrum. So ensuring that we had our inclusion criteria such as can communicate in English. That word communicate was very intentional because communicate can mean speaking verbally or typing it down or using an assisted device. We wanted to ensure that anyone who can communicate was able to participate in the study. So we made our inclusion criteria very intentional that way.
So I guess, Doug, what I'm hearing is that that wasn't clear to you as to why those choices were made.
Well, it wasn't, it's not so much,
Yeah.
I mean, that would be important too, Joseph, how the choice was made, if the choice was made. But I just want to know who the cohort was. And if they all turned out to be one level or not, that's perfectly fine, but it should qualify the results, right? And I also have to say I have a little bit of a niggling concern that I wouldn't want the assignment of the level to be made by the student group. I would like to see it be made by healthcare professionals, and presumably their advisors would have that information and so forth.
So
Yeah, that
I
makes
just wanted, sorry, Alina. I just wanted to say, like, I think both, like, okay, I don't think we are talking about different things. I think that it's important to justify why this was not asked, but I think it's also important to acknowledge that currently we do follow those DCM-5 things and, standard. And so it might be good to kind of include it, but then say why it should not be, right? So, if we want to abolish that standard, we have to start from kind of using it and then saying why it should not be, why autism should not be in DCM-5, for example, right? So it's both in a way. So I think so I would acknowledge that. I'm gonna move to Jessica to ask if she has any last questions, because looking at the time, we should move into a breakout room. And then the audience can still talk with the team. Jessica?
Yes. So I think I might know the answer for this, but I'm curious to know otherwise. Anyway, I was curious to know why you chose a tool to empower, in the setting of a clinical setting, why you chose to empower the patient with autism with a tool as opposed to try to introduce a tool in the clinic and help the doctor instead. If anyone wants to take that one.
Like, team, do you want me to
I
tackle?
can take that one. So
Sure.
there is currently a program developed by Jonathan Wise, and I think collaborators at CAMH, Dr. Lake, correct me if I'm wrong, Dr. Yona Linsky. And I forget what it's called. Elena, do you remember the name of it?
Like health literacy guide?
No.
the training module. Yeah, it's a
Yeah.
training module for and I don't know if it was CAMH or the Children's Mental Health Association or something like
It
that.
was both.
Oh, it was
working
both.
together.
Okay, yeah, it's a training module for autistic professionals to become educated in the mental health field, and for mental health professionals to be educated in the autism field.
Oh,
Yeah,
I can add on to
I can
that.
pull up the training module.
Yeah, I can add on to that because I think part of it was geared toward like the education providers. So for example, a school teacher, ISW, DSWs, like intervention support workers essentially. I know someone from my own family that took the modules, and like they talk about some of the things we talked about today, like how autism and mental health are separated, and like how autism can come with other clinical diagnoses such as ADHD, schizophrenia, and like Down syndrome and other stuff. But yeah.
Yeah. So this module already exists, and it kind of, like you mentioned, works on the other end to kind of help the professionals be able to communicate with autistic adults, because now they know things about autism and mental health. So since that's already here in the GTA and it's available, we wanted to take more of an approach with the individual, because there's not much currently to empower them. It's a lot of, systemic changes, which take a while, or changing professionals. But I think working on the individual, just making sure that they're able to go in despite the, expertise of a professional and be able to communicate what they need. I think that's super important and something that's not being done.
That's great. I actually didn't know I didn't know there was a module that was different from what I thought. So that's great to learn.
Okay, thank you very much, everyone. So we are gonna move, so the examining committee is gonna move to a breakout room when we gonna talk about your defense and about your report and everything else. In the meantime, you can stay here and you can talk with various participants. And thank you everyone for coming here today. There's a lot of people on the call. Yeah, Jordan, you setting that up, right?
Yep, I'll send you all into the breakout room now.